Assalamu alaikum. Good afternoon, everyone. It's Dania Farhat, and today I'll be talking about dermatology. We will start our dermatology videos by bacterial skin diseases, and I'll try to make these videos in English only for the sake of any international students in our faculty who suffer from the Arabic English mixed videos. In our curriculum, we have four main bacterial skin diseases. To start with, there is Impetigo contagiosum, then Eczema, then Erysipelas, and Cellulitis. So this is a table summarizing the main items in each of the previous diseases. However, we have to highlight that there are some features in common in both of them. First of all, in Impetigo contagiosum and Eczema, the causative pathogens are almost similar, which are Staphylococcus or Streptococcus or both. So Impetigo and Eczema have these pathogens in common. However, Erysipelas and Cellulitis, Streptococcus pyogenes is a common pathogen. In the predisposing factors, the first two diseases have poor hygiene as a common predisposing factor, and then debilitating disease and malnutrition is common pathogen in all of them. The main line of treatment is antibiotic. Maybe the antibiotic duration of treatment will vary. However, the main line of treatment for all of them is antibiotic, as all of them are bacterial skin diseases. So let's start with Impetigo contagiosum and let's take a closer look. First of all, it's a superficial pyogenic infection. Pyogenic means that it's caused by pus-forming organism, or there is pus formation. However, superficial is more important because superficial means that it does not cross the basement membrane. This also means that it will not leave a scar after healing. It heals with normal skin. The initial lesion in our disease is erysipelas macule, which is then converted into thin-walled vesicle, and then it forms a diagnostic lesion in our disease, which is honeycomb-colored crust, as seen in this photo. There is crust formation, and the crust color is almost honeycomb. The causative pathogens, as we have said before, is Staphylococcus or Streptococcus or both, and for the predisposing factors, we can memorize it by SPI-D. In SPI-D, this is a picture of the spy, and his name is D. So SPI D, or S, which is susceptibility or personal susceptibility, P for poor hygiene, and I for itchy diseases. And itchy disease is a very important item or predisposing factor for impetigo, as frequent itchy diseases cause severe itching, which makes the patient cause scratch marks on the skin, and this results in injury to the skin barrier, which allows the entry of pathogens such as Staph, Strep, or both, which is later on forms impetigo contagiosum. D for debilitating disease and malnutrition, and we have said that this is a common predisposing factor for the bacterial skin diseases in general. For the site of affection, impetigo occurs in any site, but it's common on exposed skin areas such as the face, the neck, and extremities, either on the upper or the lower limb. For the clinical types, we have double C, double B, and I. Double C for classic, which is a non-bolus type, and the classic type or classic impetigo is the impetigo we have just been discussing now. It starts with erysipelas macule, and the diagnostic lesion is honeycomb-colored crust, as seen in this photo. So this is the classic type. The second C refers to Cersnets. In the Cersnet, we have double C in its feature. The first C is coal lesions or small multiple lesions. We have many small multiple lesions that coalesce together and make one larger lesion, as seen here. And the other C is that there might be or might not be central healing, as the lesions from the inside and center will be central healing. So we have double C, and underneath the Cersnet, we have double C in the features. Coal lesions with small multiple lesions and central healing. Now let's move to the double B. We have bullous impetigo and Burkhart's impetigo, and in both of them we have a common item is that both of them are caused by Staphylococcus only. So Staph is the only pathogen for bullous and Burkhart's, and this is a common information that you have to memorize for your exam. For the bullous, we have, as the name refers, bully, and it's usually covered with a yellow crust. For the Burkhart's, however, again, there will be superficial, pustular, and we have already discussed that impetigo is a superficial and pyogenic infection, so we will not be surprised knowing that Burkhart's is a superficial pustular. However, the new information is that it's a type of folliculitis, and it affects the hair follicles, especially in the beard. So as we've seen here, there is also a pustular folliculitis. Now the only missing type is number 5, which is the I, refers to intertriginous, and it's, as the name refers, it occurs in flexions, such as retroauricular areas behind the ear, interdigital or between the fingers, inguinal, popliteal, perianal, or intergluteal. So it occurs in skin flexions. What about the treatment? We have said in the predisposing factors that itchy diseases are common predisposing factors, and itchy diseases result in a vicious cycle of infection. So, for the treatment, we have to memorize that we have to prevent itching either by systemic antihistaminics or systemic drugs that decrease itching, or by trimming the nails to avoid the scratching of the skin. We have local treatment and systemic treatments. The local supportive treatment include hot fermentations of potassium permanganate, antiseptic povidone iodine, and then again the main line of treatment, antibiotic. The local antibiotic creams, erythromycin is a drug of choice, and we can also use fusidic acid. For the systemic treatment, we will use antibiotics for 7 to 10 days, and we could use penicillin, erythromycin, cephalosporin, or even fluxacillin. What about Impetigo contagiosum complications? So the complications of Impetigo contagiosum, we will know them when we meet the President Sisi and drink a cup of tea with him. So this is to remind us that upon meeting the President Sisi, meeting refers to lymphadenitis, to memorize it, lymphadenitis, cup of tea, C for cellulitis, U for urticaria, P for post-streptococcal glomerulonephritis, and CC refers to SESE to remind us with scarlet fever, E for erythema multiforme, another S for spread of disease, and E for eczema. So this is just a memory aid to remind us of the complications of impetigo. Now, the next item in our table is eczema, and eczema is also named ulcerative impetigo. Why? Because it's a deep pyogenic infection, and deep because it crosses the basement membrane, and when it crosses the basement membrane, it heals with a scar, and the scar it forms is a form of ulcer. So it's pretty similar to impetigo, and the main difference is that it's a deeper infection which causes an ulcer. So it starts with an initial lesion, a small poly with clear content. The poly then becomes purulent as it's a pyogenic infection, and then it forms a tough adherent crust that when it falls leaves an irregular ulcer as seen in our photo. So this is an irregular ulcer as a diagnostic lesion of eczema. The common pathogens are staphylococcus or streptococcus or both. And for the predisposing factors, we said that spike D will be the main memory aid for our predisposing factors, but in eczema we'll replace the I with a T. So we have SPTD, S for septic focus, P for poor hygiene, T for trauma, which is recurrent trauma that causes injury to the skin barrier, and D for debilitating disease and malnutrition. Which sites are affected? Usually eczema affects the lower limb, buttocks, thighs, or leg. The main line of treatment as debilitating disease and malnutrition is a common predisposing factor. Good nutrition and multivitamins, and we could apply a local treatment as antiseptic agents or antibiotics. And for systemic antibiotics, we said that it's a deep infection, so we need antibiotics for a longer period, antibiotics for 14 days, unlike impetigo contagiosum, in which the treatment only lasted for 7 to 10 days. So we will use also almost a similar antibiotics such as penicillin, erythromycin, and cephalosporin, but the duration of the treatment will be longer, and antibiotics will last for 14 days. Now let's move to erysipelas and cellulitis. Both of them are almost similar diseases. Both of them are acute inflammation of the dermis and the subcutaneous tissue. However, the pathogen causing them this time is only Streptococcus pyogenes. It's the only pathogen causing erysipelas and cellulitis. And for the predisposing factor, we could either memorize it by the fact that spike D this time is different, in which we will replace the P with an E, or if we are an Arabic patient or Arabic student, sorry, you must know this actor whose name was Said, and this would remind you with the common pathogen, predisposing factors causing erysipelas and cellulitis, that is Said. S for skin diseases as eczema, E for edema, I for immunosuppressive diseases and the drugs, which is a common list of diseases and the common list of drugs, and D, debilitating diseases and malnutrition. We said that both of them are acute inflammation of dermis and subcutaneous, and both of them will be hot, tense, erythematous, and edematous swelling. The main difference between them, however, is the fact that if you could bring a marker and highlight the margin of the lesion, in erysipelas, the lesion will be well defined and you would be able to highlight it pretty easily with a marker. However, in cellulitis, the margins are ill-defined and you'll not be able to highlight the boundaries of or the margins of the lesion. The common site of affection are the scalp, the face, the reorbital area, abdominal wall, and lower limb. It's also highlights that the lesion will be accompanied with fever and malaise, and it's commonly associated with certain debilitating disease, which is diabetes mellitus. Now let's move to the treatment. First of all, treatment starts with good nutrition, multivitamins, and analgesics. As we have said, it's the disease accompanied with fever and malaise and so on. It's always tense and hot, so ice packs, local ice packs application might be useful. Local antibiotics also, again, erythromycin is drug of choice, and we could also apply fusidic acid. Systemic antibiotics are weekly antibiotics as benzyl penicillin or erythromycin or cephalosporin, and we could also use prophylactic long-acting penicillin and erythromycin if the case is recurrent. Now, let's move to the final part in our lecture, which is the complication of erysipelas and cellulitis. The complications of erysipelas and cellulitis, we will know them when we meet the elephant sasa. This is our elephant sasa. When we meet the elephant sasa, meet to remind us with lymphadenitis, and elephant as there is a common complication which is pseudoelephantiasis, and sasa double S double A. A starts for abscess, necrosis, and gangrene, and another A stands for acute glomerulonephritis. The last double S for sepsis, especially intracranial sepsis, and the last S for septicemia in general. So this is also another memory aid to remind you of the complication of erysipelas and cellulitis. Now I hope we have pretty well summarized the bacterial skin diseases, and thank you so much.